Thank you. Okay. Well, my name is Chris Ferrante, as she told you. I've been with Coordinated Health for several years. I've been in the area for about 15 years. I practice multiple locations. I'm in Red School Lane in Phillipsburg. I'm at Emmerich Boulevard in Bethlehem, just east of here. I go up to Wind Gap, and I'm going to be starting in Allentown very soon. So basically, I'd like to talk to you about arthritis, what it is, and how we treat it, okay? So what is arthritis? It means joint inflammation. Arthro means a joint, and itis is inflammation. And it's a degenerative condition of bone and joints, basically the ends of the bones, which is where the joints are. It's pain, swelling, and limited movement in the joints. And there are basically many different types of arthritis, okay? Osteoarthritis is wear and tear arthritis. The cartilage at the end of the bone just wears out. It doesn't work anymore. It's the most common. We're going to spend most of the talk talking about that. Rheumatoid arthritis is where your body attacks the cartilage at the end of the bones, and so the cartilage doesn't work, it gets destroyed. That's a systemic disease. People are sick in many other ways, and we've gotten better at treating that medically, so we don't do as much surgery on that. Post-traumatic arthritis is after an injury or a fracture. Maybe the bone wasn't lined up perfectly, maybe it didn't heal perfectly. That can happen in young people. It's basically treated the same way, but any injury greatly makes your chance of arthritis much worse. Aseptic necrosis or avascular necrosis is a process where the bone dies, and that causes pain. It's treated similar to arthritis. All the techniques we talk about are useful for that. And infectious arthritis is a whole different kettle of fish. That's when the joint gets infected and the cartilage dies for a different reason. Arthritis is a big problem. About 40 million Americans are affected with it. At least 20 million people suffer from osteoarthritis primarily. So it's a big problem. To try and understand it, we can talk about what a joint looks like. This is a synovial joint. This is the cartilage, this gray layer here, okay? There's a synovial membrane here that releases fluid. There are tendons, ligaments around it, but this is the area that wears away in arthritis. And basically it goes from being nice and smooth like this to being ragged and jagged, and this doesn't support the bone at all. So this is what arthritis looks like schematically. The symptoms are pain in the joint. That's really what we care about. It's generally worse with using more often. Some people hurt at night. It's more from beating it up during the day and you're just thinking about it then. It's better with rest, and the stiffness is generally relieved by moving it around. To diagnose this, we would do a history. We'd find out when you have pain, what makes the pain better, what makes the pain worse. We'd do an examination on you, and we'd always get x-rays. Sometimes we get blood tests to rule out other diseases. Very infrequently, we'd want to get an MRI. An MRI is not necessary to diagnose arthritis. If we're getting an MRI, it's usually to make sure something else isn't going on. Okay? In terms of treatment options, this is basically the way we go through it. We start with stuff that's easy and get to the harder stuff as we go on. The use of heat and cold can be very beneficial for arthritis. Moist heat can greatly loosen up and limber up the joint. You can put a hot pack on for 15 to 20 minutes, somewhere in the neighborhood of 3 times a day, helps greatly. This is great to get it moving and get it feeling better, but it's really bad for an acutely inflamed joint. For that, ice therapy or cold therapy works a lot better. Ice packs can be put on, again, for 10 to 15 minutes. You have to make sure you have a towel or some padding on it so you don't have a burn from it. But this helps greatly. I actually do this quite a bit. I kind of have a bad knee myself. For exercise and weight control go together. Okay, this is actually probably the best way to treat arthritis at an early stage. Exercise can get the muscles around the joint stronger. They can get the motion better, and they do a great job in decreasing symptoms. Exercise is also a way to get to weight control. The weight control helps on multiple levels. There's less load on the joints, so it decreases how quickly they wear out, and if they're starting to wear out, it hurts a lot less. So these are the mainstay of what we do early to try and decrease the discomfort. If these don't work, we can progress to some kind of medication. There are many options for this. There are over-the-counter medications that work, okay? Non-steroidal anti-inflammatory drugs like aspirin, ibuprofen, or naproxen. We also have Advil, Motrin, they're types of ibuprofen, and Aleve is a type of naproxen. They stop the inflammation. They decrease the reaction to the irritants, and decrease the swelling, decrease the discomfort, and decrease the pain. They're very effective. They do have side effects, unfortunately. Some people can't take them, and some people can't take them for long. Acetaminophen is another over-the-counter medication. It helps the pain. It doesn't actually decrease the inflammation, but makes you feel a whole lot better. COX-2 inhibitors are better anti-inflammatory medicines in that they only work on certain types of the enzyme. They're a little easier on the stomach, and they don't cause ulcers as much. Celebrex is the one that's out there now. There used to be Bextra and Vioxx. They were taken off the market. They were a little stronger and had a little more side effects. But you know, these don't have no side effects, but they're a little easier on the stomach. Vitamins and nutritional supplements can be used for this. There are a great number of these. They're not completely benign, and you should probably talk to your medical doctor about it or your orthopedist and make sure there's not a problem with it. But the ones that are pretty safe are glucosamine and chondroitin. They are generally used together. They have some positive results. They do have a mild to moderate relief of pain. It usually takes a while to kick in, results in about 8 weeks, and I think these are pretty beneficial. A couple years ago, I had my wife start taking these for her hip, which means I either think they work or I don't like my wife. After medications would work, we have steroid injections or joint fluid therapy. These are different types of injections we can do in the joint. Liquid cortisone breaks up the inflammation and decreases discomfort in that way. It's very good. There's a limit to how many you can get. Basically, it's no orthopedic surgeon will give you more than 3 in a joint over the course of a year. They don't have to be every 4 months, but no more than about 3 in a year. They do, if you're diabetic, it can be some issues. They do slightly raise the risk of infection, but they do make you feel a whole lot better. Hyaluronate or hyaluronic acid, there are many brand names, Synvisc, Hyalgan, Supart, Euflexa. They're all kind of like Coke and Pepsi in that they're the same, they work the same way, but they cushion the joint and they lubricate the joint and they work pretty well. They're either given as a series of 1 or a series of up to 5. Most of them give 3. And these can be pretty effective. They're pretty low risk. There's very few side effects with this. And if none of these work, surgery is an option. Now, surgery is the last option. It's the only way to cure the disease. Everything else we do is just managing the disease. But we probably should try some other things first before we jump into surgery. In terms of surgery for arthritis, there are basically 3 big areas. One is arthroscopic debridement, where we go in and we cut off the bone spurs on the joint. This doesn't work very well, unfortunately, but people come in saying, can you just do a scope? I talk about it because it doesn't really work, so I wouldn't recommend it. Osteotomy is a great option for very young people. With that, we take the joint and we realign it. If you're collapsed down on the inside, we'll change the position so the pressure's on the outside of the joint. We take the pressure from a worn out part of the joint and put it on a not worn out part of the joint, and this can work pretty well. It wears out eventually, but it's good for people who are very high demand or very young. Joint resurfacing, either a joint replacement, is kind of the gold standard. It's what we do most of the time. It's a very good procedure, and I'd like to talk mostly about that. Basically, I do hips and knees, so I'm not going to talk that much about shoulders or elbows. We have excellent surgeons that coordinate it would do that. We have a lot of people who do shoulders. I'm probably, the spine guys and myself are probably the ones who don't do it. But for the knees, we cut out the damaged parts of your knees. This is really a resurfacing. We just cut off the end of the bone, and we put an implant in that's about the size of the ends of your bone. So basically, this is a schematic. This is a worn out joint with very jagged cartilage and very thin cartilage. So we'd go in, we'd make an incision on the front, and we'd cut off the diseased portion, get down to good bone, and we make this perfectly shaped to be the back of the component that we're going to put on. And then we put a metal component on. Usually it's metal, it can be ceramic, it can be other substances too, but generally we make it out of a metal. And this is attached to the end of the femur using bone cement. And the cement just holds it there and keeps it nice and tight on there. For the tibia, we do a similar thing. This is just a straight cut across the bone that we do, and we make a hole for a little stem, and we then cement a piece of metal in there also. We then put plastic in there. This is ultra high molecular weight polyethylene. That means it's fancy plastic, and that's your new joint surface. It wears out over time, but generally these last somewhere between 15 and 20 years, all comers, sometimes longer, sometimes less, but it's pretty good, and people do fairly well with this. It greatly decreases the pain. A hip replacement, like I said, a knee is actually a resurfacing. We just cut the end of the bone off. For a hip replacement, it's actually a replacement. We cut part of the joint out. We cut the damaged people out and replace it again with metal, okay? We get to the joint. I'll talk more about how we get there a little later. And so we'd go in, we'd make a perfectly round-shaped hole here in the acetabulum. We use something that looks like a cheese grater for that, a reamer that makes the hole the perfect size. And we then bang this metal in, okay? I always use screws. Some people do, some people don't. It's kind of dealer's choice as to what you want to do. We very rarely will put this in with cement. It seems to work much better if we just wedge it in there very tightly, and it's a very rough metal that the bone will grow into. And that stays in place. For the stem, we broach a hole in the bone that's, again, the perfect size for the metal. And then we put a piece of metal in there that's a stem with something here to put the head on. And there are two ways this can go in. This is a time when we often do use cement. 30 years ago, almost everyone got cement. Now we found that if we don't use cement, it has certain advantages. If you put it in with cement and the person falls or something and breaks the cement, it's broken. If we don't use cement, and again, if the bone grows into the rough surface, if something happens and it moves a little bit, the bone can grow back into it. So it's an advantage with that. And the studies probably say that if you can get away without using cement, they tend to do a little better. But either way, we then put a ball on, okay, and this can be multiple materials. Most of the time we use metal. Metal works very well. We can use ceramic, or we can use oxidized oxinium, which is a type of ceramicized metal. Ceramic has a little less wear, but ceramic can break, so you'd have to talk to your surgeon about it and weigh the options. Metal's great for most people. And that's the hip joint. Of all the surgeries done by all the surgeons in the world, total hip replacement is #1 in terms of patient satisfaction. People have a lot of pain beforehand and they have much less pain afterwards. So it's a great operation and my favorite operation to do. In terms of how you get to the joint to do the hip replacement, in the past we tended to approach it from the back, and we had to cut quite a few things for this. This is a picture of it. This is coming from the back. That's the big muscle of the gluteus maximus, the big butt muscle. We split that, and then we have to cut these little tendons off the bone to do so. And it disrupts the muscles. We have to cut things, and they have to heal. Afterwards, because we went through that area, it hasn't healed yet, and there's always a risk of dislocation. It's pretty high for the first 6 weeks or so, and then goes down to an acceptable amount. And because there's a risk of dislocation, we limit where you can put the hip. You can't squat down. You can't go in a low chair below 90 degrees. And you can't put your leg in certain positions because it could possibly pop out. You have to use some kind of supportive device because the muscles have to heal. And people do pretty well at 6 weeks to 3 months, something like that. And because we cut things, there's a greater need for pain medication. So a lot of people, because of this, don't want to deal with the discomfort and the pain and the long recovery, so they don't get a hip replacement and continue to live with the pain. There is a better approach. It's not completely new. It was described a long time ago, but people are just starting to use it for hip replacements, where we approach the hip from the front, and we don't cut muscles doing this. We push the muscles out of the way. It's a muscle-sparing approach, and it can be a smaller incision, certainly, than the posterior approach was many, many years ago. This is the picture of this. We come and we take this muscle, and we basically cut through the fascia and then just push the muscle out of the way behind. We can then get right to the hip from that. It's muscle sparing. We don't cut any muscles for it, so it's improved in that. And as you can see on this picture, you can see how close we are to the skin here and how far we are from the skin here. So it's just much easier to get in. It's a shorter distance to get to. And because of that, there are certain advantages in doing an anterior hip replacement. We do need this special table to do it. This is called the HANA table. It stands for hip and knee arthroplasty. And it allows us to put the leg in positions. It allows us to do the operation through one small incision in the front. There are several of these at the Lehigh Valley. We have one at the Allentown Hospital, and it greatly facilitates doing this operation. It can be done without the table, but it's much easier with the table. Another advantage of doing the anterior hip, and probably the clearest advantage to me, is everything else is a slightly higher chance of something, is we can make sure your leg lengths are really close to perfect, because we look at it with fluoroscopy and we can compare one side to the other. We're looking at the left hip if you're having the right hip done, and can make sure that everything comes out to be just about the right length. It's not a common occurrence to have a leg length inequality, but usually if your right hip is arthritic, your right hip is a little shorter because that cartilage has worn down. So we at least make you longer for a little while. We make you longer and you have to get used to it. So it feels very long for a while. They're about even and you get used to it, but so then this position assures that we're in a good position. Okay, so there are advantages. There's certainly less risk of dislocation. This has been borne out by the studies. The risk of dislocation for a posterior approach is somewhere in the neighborhood of 4%. From an anterior approach, it's probably about 1/10 of that, maybe 0.5%, something like that. You don't have hip precautions. You get up and do what you want right after the surgery generally, so we don't have to have the pillow between your legs, and you can move around more. And there's generally less pain and faster recovery with this. So there are certainly some advantages to this. So I've kind of gone through it. I'd like to take some questions here and then talk to you over at the booth if you have any questions after that. So anyone have any questions?
Why don't you just do the anterior hip approach on everyone?
There are certain people you can't do an anterior hip on. Okay, shorter necks are very difficult to do it with. Heavier people are more difficult to do it. And the answer, honestly, is I started doing posterior approaches. We didn't really have anterior approach. They weren't done when I learned how to do them. So I did the anterior approach many years ago. I was actually the first guy to do them in the Lehigh Valley, and I didn't really like them. It took me 3 times as long to do them from the anterior approach. I did about 7 to 10 of them, something like that, and I thought they were more difficult. Then I've done posterior approach again for about the last 7 years, and now I've started doing the anterior approach, and people do seem to get up and moving a little quicker and feel a little better and like it better. Okay? Yes?
What are the limitations of a hip replacement when it comes to sports like golf, swimming, etc.?
Okay, I tell everyone you can't run and you can't jump, okay? So like if you play basketball, you're not jumping up for rebounds anymore, okay? The more you use it, the quicker you're gonna wear it out, whatever you do, okay? But, you got the hip so you can live your life and do what you wanna do, okay? You can certainly play golf, okay? You can certainly walk. Okay, when I say no running, I'm talking running for exercise and running for fitness. I'm not talking about playing with a grandkid and running after them playing tag or something. That you can do. But, heavy exercise you can do. You can lift up as much as you want. That's not really the limit for it, okay? We worry about dislocation if we do a posterior approach. We certainly worry about it for the first 6 weeks. But the limits are you can't run and you can't jump, basically. And someone asked me if they go skydiving. I didn't want them skydiving after a hip. Skiing would bother me quite a bit after a hip because if the hip turns, no matter what, it could pop out. Knees I would let ski. But so minimal limitations, okay? There is a lot of therapy after a joint replacement, either a hip or a knee. A knee's probably a little worse, but you're generally doing at least 6 weeks of therapy afterwards. Generally, it's out to about 3 months or so. And, they have to strengthen the muscles, they have to stretch them out, they have to get the motion back, and that's it, okay? As I said before, that these last somewhere 15, 20, 25 years, depending on exactly how they're done and what materials and how active you are. They do wear out, okay? When they do wear out, there are a couple of options, the best of which is take it out and put in a new one, okay? It's called a revision surgery, and that's what I spend most of my time doing, actually. And it's a more difficult surgery, it's a harder operation and longer, but then the results are a little worse. If 95% do real well after a first operation, maybe 90% of people do real well after a revision operation, okay? So there are other things with that. Yes?
How many cortisone shots can you get in the knee? And does the shot work in a sprained ankle?
You can have about 3 a year. Okay, for the knee, all right? Beyond that, the risks of problems are significant, okay? Cortisone hurts the cartilage a little bit at the end of the bone, okay? The local anesthetic we give also hurts the cartilage at the end of the bone a little bit, okay? It's not much. I've had many cortisone shots in my knee, but it does, like the viscosupplementation, the hyaluronic acid, that doesn't really damage the knee, okay? So you can have 3 of them a year, basically. In terms of could you get one for a sprained ankle? You could. A sprained ankle is more of there's a area that is torn. It will help in the short term, it'll help the pain and discomfort, but the cortisone causes it to shrink down. It doesn't really help the ligament to heal. So, it's not something done as much. It's done for athletes. They have a big game. They get a shot. Mostly that's local anesthetic, but they get cortisone also. It can be done, and if it's just hurting you real bad, but it doesn't really, it doesn't break up inflammation or help improve it like it would for hip or knee arthritis.
Why do professional athletes recover from knee injuries so much faster? What are they doing differently?
They have physical therapists working with them all day long, and that's all they're doing, okay? That's their job. For most of us, we have other things to do. If we sprain an ankle, we spend an hour in therapy, we maybe do some exercises. We're not doing as much for it, okay? Back when I was a resident and since then, the studies, all the studies at the military academy and the naval academy looking to see how like a hand fracture would do or something, they did better than anyone else. And the reason was, just like the professional athletes are doing nothing all day but working, if you go to the military academy and they tell you to do therapy, you're going to do therapy. It's not like the rest of us where, okay, we'll do it a little bit. But professional athletes are the same thing. They have to do a lot more therapy than the rest of us would do. Okay. Yes, sir.
For knee surgery, I heard about quadriceps sparing. Do you perform that type of knee surgery?
Okay. Years ago, when any of us did knee replacements, we went right through the middle of the quadriceps tendon, okay? And then we went around the side of it and went down, okay? That really causes problems with your using the knee afterwards and the therapy afterwards, okay? We can't really hold it well. The stitches tend to pull on that. Everyone now, instead of going through the middle of the quadriceps tendon, we go off through the muscle next to the quadriceps tendon. So we don't violate the quadriceps tendon with our cut, and the movement is much quicker afterwards. The recovery is much sooner, okay? There is another type of surgery called a quadriceps sparing, where instead of going through the muscle, they go medial to the muscle and they make a smaller incision, okay? And they do all the work from the side. That was a pretty big years ago. But it's much less accurate. We couldn't get I never did it, but the people who did it couldn't get the prosthesis in as accurately as we can from just cutting the muscle a little bit above. So a quadriceps sparing, almost no one does it anymore because it was so inaccurate, okay? Most people are sparing the quadriceps tendon, like I said, and everyone does that. No one goes to the middle of the tendon anymore. The quadriceps sparing, many, many years ago, I don't know if any of you ever heard of a 2-incision hip. One company did it where you made a little incision in the front and a little incision back here, and that was all the rage back 20 years ago, 15 years ago, and they broke too many bones. They just didn't work very well. So no one has those anymore. Those are out, okay? And the quadriceps sparing approach is very similar to that. You can't get it in nice, you can't get it in well without fracturing or without complications, okay?
What is less invasive knee surgery?
Okay. Less invasive is basically going to the side of it instead of going through the quadriceps tendon, and that's something everyone does it that way. Some people make a slightly longer skin incision, some people make a slightly shorter skin incision, but I don't think anyone's done a non-less invasive surgery. I mean, I used to have slides for less invasive surgery. It's the standard now. It's what everyone does. We just cut a little less on the inside, and the recovery is much quicker, and there's less pain after surgery. Okay?
Are the parts you use in knee surgery made specifically to match the person's bone?
For knee replacements, there's one company that does custom make the implants for you, okay? They get a CAT scan and they make the implant, okay? I don't use that, okay? That's like 5 times the price, okay? And it's just not, the insurance wouldn't pay for that. Instead of small, medium, and large, we have really small, we have somewhat small, we have small, we have a little less small. We have about 13 sizes, okay? But yes, it's an off-the-shelf size, okay, that we use. A couple of years ago, and I guess it's still done a little bit, they do custom knees, they'd say, okay? As I said, one company makes a custom knee, it's Conformis. Other companies make custom cutting jigs, okay? Which I just found to be, you have to get a CAT scan, which is more radiation for you. It's more time till the surgery. Those take about 6 weeks to get. And I just never found an advantage. I don't think the cuts done with the custom jigs were any better.
Are any knee replacements 3D printed?
The company that makes the custom one, I don't think they use a 3D printer because that's extremely expensive. But they custom make it from some machining process, which I'm not exactly sure how they do it. The other ones are not really made by 3D printers or anything like that. I guess I didn't tell you for knees, okay, generally the top piece is made out of cobalt chrome, which is a very hard metal. The bottom is made out of titanium, which is a softer metal, okay? Titanium is a more expensive material, but titanium is so much easier to work with that the cobalt chrome, the femoral prosthesis, becomes way more expensive. The femur has to be made out of cobalt chrome. You cannot make it out of titanium. It would not work. It's too soft. It would wear away. You can make the bottom one of whatever you want, and the titanium saves a little weight and saves a little expense for the companies making it. But no, they don't use a 3D printer to do it, to answer your question. Sir, you have a question?
When selecting the size of the knee replacement, is that something you do beforehand or during the surgery?
Both, okay? In reality, all the sizes are there, okay? Except for the very smallest size and the very biggest size. And if there's a chance that you need one of those, you know, it's a big guy, I say bring the biggest size, okay? I've never used the smallest size. So, and if it were a very small person, I would certainly have it available. But they have, you know, 11 of the 13 sizes, every single case, bringing it in, okay? For hips, we do tend to figure out exactly where we want to put it and exactly what we're going to do so we can make the leg lengths as close as possible. And we do it with x-ray. We have they put little pictures of what the implant will look like on top of it, and you know, maybe get those pictures if you want afterwards. But for knees, it's, you know, it's better to just measure off the bone when you get in there. I used to template it and figure out about what size it was, and we were wrong half the time. And they have everything there anyway, okay? Another interesting thing about knees and sizes is somewhere in the neighborhood of 8 or 10 years ago, they started making women's knees. I joke to people that they're pink instead of silver, but what it is that women tend to have a longer knee from front to back than they do medial to lateral. So the original knees were just made off of men's knees, and no one even thought they were different. And about 8 years ago, some of the companies came out with a woman's knee, and they fit a woman's bone a little better, okay? My patients do better since I use those, but there are some other things involved. I don't know if it's that much of a difference, but so, you know, every woman I do has fit better with a woman's knee. Some of the bigger men have fit better with a woman's knee, so they, you know, it's called a woman's knee. It's not really, it's just, that's the shape it usually goes with.
What is wearing out in the knee after 15 to 20 years of use?
Okay, it's a good question, okay? I said there's metal and plastic. The metal really doesn't wear out, okay? The plastic, every time you move, you release particles of plastic into the joint, okay? So one thing that can happen is the plastic can just wear down over the course of many, many years. What is more likely to happen is these little particles of plastic are floating around in your joint, and your body doesn't want them there. So your body tries to send cells to digest them, okay? Macrophages go and try and ingest these little particles of plastic. Now, we can't digest plastic, but so the enzymes we release to try will eventually wear away the bone, and that is called osteolysis, and that is how all joint replacements currently made will eventually fail, okay? Now, eventually can be 60 years, okay, or eventually can be much shorter than that, but that's how they'll all eventually fail, okay? We haven't, I mean, they've tried everything. They've tried ceramic on ceramic. It's too hard, it breaks. They've tried ceramic on plastic, it's a little less wear. But all of them fail eventually from this particle debris. And osteolysis is this process whereby they fail. Okay, I think they're telling me that it's about time to wrap it up. If you have any other questions, I'd be happy to talk to you about it in the booth. I'd like to thank the Morning Call for the opportunity to speak here. Thank you very much.